Hello, I'm Dr. Ken Delcart. I'm a former primary care physician and a current geriatrician. And today we're going to have an introduction to the history of United States healthcare and insurance in America as part of the Northern New England Physicians for National Health Program summer internship. So, how did we get here? Bleeding and purging, as you all know, has progressed to current genetic modification of illness via CRISPR, protein design by artificial intelligence, and the routine application of monoclonal antibodies to therapy for illness. We've come a long way, and initially we'll learn about how the origins of American medicine looked in the turn of the previous centuries, how the scientific method altered perception of medicine. Consider self-reliance of an agrarian 19th century America and how those traits were idolized into myths that endure into today. We'll consider factors that enhance societal respect and authority of physicians as care improved, and cite the American Medical Association's role in professionalism and racism. So, in the colonial age and into the mid 1800s, medical care was based on 2 years of formal medical training. It was apprentice based in doctors' offices and communities, is anecdotal, and based on the Greek model of Galen's four humors, which included blood, phlegm, yellow, and black bile. And doctors often struggled financially. They held little status, and they competed vigorously for patients and revenue at a time when their outcomes were questionable. This profession of medicine in the 1800s was divided, weak, ineffectual in raising many standards of care, and did not have privileged status, as agrarian self-reliance and experience would often have better outcomes in providing home remedies. So, in the 19th century, bleeding and purging was the mainstay of treatment, which was a pretty dramatic alteration of homeostasis, which would certainly gain a patient's respect for the tools, but not necessarily the outcome. There's a great example of the yellow fever outbreak in 1793 in Philadelphia. That was killing at least 20 people a day, and Dr. Benjamin Rush, who was a icon of medicine at the time, the signer of the Declaration of Independence, took the following approach to treating his patients. This is out of the book Hamilton, interestingly. You'd have a febrile, sometimes jaundiced patient that he would empty the patient's bowels 4 or 5 times using potions and enemas, then drain off 350 cc's of blood to lower the pulse, and then induce vomiting, all of which was to be done 2 or 3 times a day. As you can imagine, this did not portend well for the patient. Fortunately for Alexander Hamilton, he had a friend who was also a physician who had experience with treating yellow fever in St. Croix in the Caribbean. And this physician advocated rest, chamomile, oil of peppermint and lavender, and tincture of opium to help induce sleep at bedtime. You can imagine that Hamilton survived his yellow fever, and as did this doctor's patients. So, home-based remedies were often superior to what the elite physician of the day could provide. Hospitals, of course, also were places of last resort for those who were with chronic incurable illness, homeless or insane, and the poor. They were unsanitary as well. So here's a couple of tools of Benjamin Rush in terms of some of his cupping and other devices. Here's some magic oils and the like, which extend to this day, as we might see with hydroxychloroquine and whatnot. And as to medical insurance, there was a need for disability insurance, but not medical insurance. Income stabilization if one lost their job because of loss of an arm or illness was required, but care was inexpensive and ineffectual. What was established in Europe during this time were sickness funds, which would support widows and families. This goes back to the Middle Centuries, to the Middle Ages. So Germany and Britain had some established funds to help serve as a familiar framework on which medical insurance could be expanded in the 1900s. The U.S., on the other hand, had few similar such so-called benevolent societies, or perhaps immigrants who brought such societies with them. But for the most part, in the U.S., there were not such organized groups to serve the injured or the widow at the workplace. In fact, Ralph Waldo Emerson published Self-Reliance, which talked about idealized individualism instead of the use of community cohesion. So, as to insurance, there was accident insurance, funeral insurance, and others that developed during this era. Not long after, of course, in the background is efforts to create a organized formulation of the world via science. And anesthesia was one of the first revolutions to reach medical care. Here's a picture of Morton using ether to allow for surgery in 1846. Germ theory with Koch and Pasteur followed, and aseptic techniques as first discovered by Semmelweis with washing of hands after a cesarean section or treating a patient who had postpartum sepsis. John Snow removing the Broad Street pump handle such that he could resolve a cholera epidemic. All these things were happening as revolutionary in the mid-1800s. And such advances clearly led to reforms in medical education as a consequence. Also, I should not neglect Florence Nightingale was revolutionizing nursing care as a way to provide organized, compassionate care. So professionalism in various fields was going hand in hand with the scientific method. And the European model became embraced by elite U.S. medical schools, which would provide anatomy, pathology, and clinical courses, and would affiliate with universities in their midst. And training would now extend from 2 anecdotal years to 3 years of formal education. The academic year would expand from 4 months to 9 months. And Johns Hopkins, as such a paradigm, opened in 1893 with residency training. And essentially, medicine was becoming a complex endeavor. Along with that, professional sovereignty and respect was rising. The former role of hospitals as sick houses were being converted into citadels of modern care. Such hospitals started to develop in most American cities. And Boston, for instance, for the Brahmins of Boston and the well-off would be Massachusetts General Hospital. However, for the less fortunate and average Bostonian would be the Boston City Hospital. In Philadelphia, likewise, Pennsylvania Hospital would serve the elites and the well-off, and Philadelphia General Hospital served the other communities. During this time, out-of-pocket payment was the really only means of payment. There was still no necessity for medical insurance. Basically, the poor would exchange their care, if they could not pay out of pocket, to serve as what you might know as clinical material, quote unquote. They would be trained on by residents and learning physicians. The well-off would provide revenue for the hospitals that served them. Here's some examples of wards of the day. So allopathic medicine was ascending during the late 1800s, and such by the turn of the century in 1900. It was recognized that there need to be radical reforms in education. Many medical schools, as of 1900, still were simply 2-year anecdotal programs run by local doctors for profit and had not yet incorporated scientific teaching. The American Medical Association basically decided to organize medicine around science-based principles and hired Abraham Flexner to come out with this Flexner Report, This radicalized and proliferated the understanding, disseminated the understanding of science and its lack thereof in American medical training. And when it came out in 1910, it blew the doors off of medical schools by attacking deficits in quality and content. And as a consequence, many medical schools closed. But fortunately, there became a standardization in scientific curriculum and prerequisites. The AMA during this time also strengthened state medical licensing. And as such, the AMA gained power because it was able to introduce medical boards in each state, assure continuity and uniformity in medical education. And essentially, the AMA was growing power along with the legitimacy of medicine in its profession. Not to neglect the racist history of the AMA. James Marion Sims, who was previously a plantation physician, actually took interest in gynecology, came to serve as the president of the AMA, but he performed experimental fistula surgery without anesthesia on enslaved black girls and women. These subjects were forced to serve as domestics or nurses in the clinic, and he operated on them under the myth that black people were impervious to pain. And this was some of the proliferating history of racism in America. The AMA, again, was initially founded in 1847, and when it was founded, it did not exclude northern states or various states from accepting black doctors. But by 1870, during another age, the National Medical Society was developing to represent the needs of black American physicians. They were excluded from attending AMA meetings. And as a consequence, they had to form their own official association in 1895. With the Flexner Report in 1910, unfortunately, black medical schools were forced to close, and likewise, black doctors were excluded from medical societies and medical boards and could not gain hospital privileges. So there was a mixed history, of course, as you might imagine. As the 20th century progressed, the American Medical Association did improve medical care by advocating for consistent education and science-based programs. It gained power via this medical education and licensing. But on a consistent basis, when health insurance reforms were proposed, the AMA opposed such reforms. Any governmental intrusion into healthcare coverage dates back to the turn of the last century, and it also opposed direct employment of doctors by hospitals, insurance companies, or large employees. And again, thinking about how the AMA defended doctors' independence from the needs of industry, we will consider how that might have changed in more recent decades. So, I think that's it for this first presentation, and look forward to seeing you further.